Welcome back, guys. This is Circulatory System Lecture 3, Part B. So in Circulatory System Lecture 3, Part A, last time we were discussing the EKG recording or the ECG recording. So we were looking at the 12-lead ECG machine. So we use the 12-lead ECG machine to look at the heart. So the 12-lead ECG machine, you have 12 leads in which we are going to look at the heart. So there are 12 angles. So we said of those 12 leads, we had 6 limb leads and 6 chest leads. The 6 limb leads, we had 3 which were called bipolar leads. The 3 bipolar leads, you have lead 1, 2, and 3. So for lead 1, these are called bipolar because you have 2 electrodes that are connected to the body surface. Then from the 2 electrodes, you'll be able to look at the heart. So it will pick up the electrical signals from the heart. And then that will be able to produce a tracing on the ECG. So each lead will be able to give you a tracing on the ECG graph paper. So for lead 1, we say that we put the negative electrode on the right arm and the positive electrode on the left arm. That's lead 1. So it's looking at the heart from the lateral aspect of the heart. So that's lead 1. Then we had lead 2. Lead 2, we had the negative electrode that was connected to the right arm, and the positive electrode was connected to the left foot. Then we had lead 3. The negative electrode was connected to the left arm. Then the positive electrode was connected to the left foot. So it was that triangle, which is called Einthoven's triangle. So they will have those schiste angles, okay, schiste giving you that isosceles triangle. So that is called Einthoven's triangle. And then on top of that, we also had the augmented limb leads. So these are called augmented unipolar limb leads. So they are called unipolar because you only have one electrode that you connect to the body surface, and then the ECG machine will calculate the average between the 2 electrodes, and then it will use it as a negative electrode. Then you'll be able to pick up the electrical signals from the heart. So we had 3. We had AVL, which was connected to the left foot. So it will be looking at the heart from the inferior aspect. And then we also had AVR. The AVR is augmented voted right arm. So it's looking at the heart from the right arm downwards at that angle, AVR, which was at negative 150 degrees. Then we had AVL, which was looking at the heart from the left shoulder, looking downwards at negative 30 degrees. The AVF was at 90 degrees. Then lead 1 was at 0 degrees. Lead 2 was at 60 degrees from lead 1. Then we had lead 3, that was 60 degrees from lead 1, starting from the 180. So it was at 120 degrees plus 120 degrees. So those were the limits. So they were looking at the heart from the vertical aspect or the frontal plane of the heart. So the vertical plane of the heart. Then on top of that, we had 6 chest leads. These are V1, V2, V3, V4, V5, and V6. They were connected on the chest, so they are also called precordial leads. Precordial leads. So we had V1 that was placed on the 4th intercostal space. How do you locate the location where you're supposed to put your V1? First, you feel for the sternal notch, then you palpate for the sternal angle. Once you find the sternal angle, you just move to the right side. You'll be in the 1st intercostal space, and then you feel for the 2nd, 3rd, and 4th intercostal space, just to the right of the sternum, but adjacent to the sternum. That's where you put your V1. Then you do the same, feel for the sternal notch, sternal angle into the 1st intercostal space, 2nd, 3rd, then 4th intercostal space to the left of the sternum. That's where you put your V2. So V1 and V2 is looking at the heart from the anterior aspect. So these chest leads, they are looking at the heart in a horizontal plane, but V1 and V2, they're looking at the anterior aspect of the heart. And then from there, you need to place your V3 and V4, but before you place your V3, you need to start with V4. So for the V4, you need to feel, since you're already in the fourth intercostal space, you go into the fifth intercostal space, then mid-clavicular line. So you know the collarbone or the clavicular bone, then mid-clavicular line all the way down the left part of your body. But in the fifth intercostal space, that's where you put your V4. Then somewhere in between V2 and V4, you put your V3. So it means your V3 and V4, they are mainly looking at the septum of the heart. So the horizontal plane, but mainly looking at the septum of the heart. Then from there, you need to put your V5 just on the left aspect of V4. So just move on the left aspect of V4 within the fifth intercostal space, you put V5. Then V6 is just under the armpit in the mid-axilla line. So just within the fifth intercostal space, but under the armpit, just on the lateral aspect of the body, that's why you put your V6. So it means your V6 and V5, they are looking at the lateral aspect of the heart. So the V6, V5, lead 1, then you have AVL, then you have lead 2. They are all looking at the lateral aspect of the heart. So from there, we also discuss the cardiac access, to which we said for you to know whether it's a normal cardiac access or abnormal cardiac access, you need to look at the ECG tracing. So if you check the ECG tracing, you find that your lead 1 wave are mainly positive, then you check for lead 2. So if lead 1 is positive, you check for lead 2. So if your lead 1 is positive, then your lead 2 is also positive, then you have the normal cardiac access. So this normal cardiac access is found between negative 30 degrees and 90 degrees. So anything within that sector of the circle between negative 30, which is your AVL, and 90, which is your AVF, any wave that is produced within this sector is called the normal cardiac access. But if you check, your lead 1 is positive and your lead 2 is negative. So if your lead 1 is positive and your lead 2 is negative, it means you're going to have left axis deviation, in which we said in most cases when you have left ventricular hypertrophy, that's where you're going to have left axis deviation. So the cardiac axis now will shift to between negative 30 and negative 90. Then you have your left axis deviation, which is also called LAD. Then from there, if your lead 1 is negative, then you check for AVF. So if your lead 1 is negative, then your AVF is positive, then you're going to have right axis deviation. So the cardiac axis now will be between positive 90 and 180. So between 180 and positive 90, you have the right axis deviation. In most cases, when you have left ventricular hypertrophy, then you can have, when you have right axis deviation, in most cases, when you have right ventricular hypertrophy, you're going to have, right axis deviation. Then we also said if your lead 1 is negative, then your AVF is also negative. It means you're going to have extreme axis deviation, which is also called the northwest deviation. So the northwest deviation is not common. So you find that within the northwest deviation, your cardiac axis will be between positive 90 and negative 90. That is called the north axis deviation. So that one is very rare, so you won't encounter it when you're looking at the ECG tracing in most cases. So you can have left axis deviation or right axis deviation depending on the type of hypertrophy you're having. Sometimes nerve blocks or heart blocks. In general, heart blocks can also result into these access deviation or any other type of bradycardia or tachycardia. So tachycardias can also result into access deviation. So you are talking of abnormal cardiac rhythm. So now it brings us to cardiac arrhythmias or heart blocks. So heart blocks are special types of cardiac arrhythmias. So that's why we are discussing cardiac arrhythmias and heart blocks. So there are different ways in which you can classify cardiac arrhythmias. So depending on the position of the heart where you're having these or the origin of these cardiac arrhythmias, you can have supraventricular cardiac arrhythmias that are taking place above the ventricles, or you can have cardiac arrhythmias that are affecting mainly the ventricles, so they are called ventricular cardiac arrhythmias. So you have supraventricular and ventricular cardiac arrhythmias. On top of that, you can also classify cardiac arrhythmias depending on the heart rate. Remember, we said for you to have a normal cardiac rhythm, you should have the normal heart rate, which is between 60 and 100 beats per minute. Why? It's because the SA node is firing at the rate of 60 to 100 action potentials per minute. So you should have 60 to 100 beats per minute. So for you to have a normal cardiac rhythm, the heart rate or the heartbeat should be between 60 and 100. On top of that, you should have the action potentials that are originating from the Xenoatrial node. So from the SA node. If the origin of these action potentials are coming from the different parts of the heart, that can also result into cardiac arrhythmias. Then on top of that, we also say that these action potentials that have been generated by the SA node, they should be conducted within the normal conducting system of the heart. So from the SA node via the internodal fibers to the AV node, from the AV node to the bundle of His. From there, it needs to go to the bundle branches of His. So you have the right bundle branch and the left bundle branch of the His to the Purkinje fibers, and then to the ventricles. That's the normal conductive pathway. Then on top of that, we also say that these action potentials, they need to be propagated within the normal velocities. Remember, from the AC node into the internodal fibers, the atria, the rate of conductivity of action potentials is between 0.5 to about 1. Then we said within the AV node, there's a delay there. So the speed, it's very slow. It's between 0.03 to 0.05 meters per second. Then within the bundle of His, it will start increasing. It will be 2 meters per second. Then the Purkinje fibers, they're the fastest, which are about 4 meters per second. Then the myocardium, you're talking about the atria and the ventricles, they will conduct action potentials at the speed of about 1 or 0.5 meters per second. So those are the normal velocities. So you have normal velocities, normal heart rate, the normal origin of action potentials, SA node, and also the normal pathway. So then you have a normal rhythm. Anything that is missing one, then you have cardiac arrhythmias. So you can also classify cardiac arrhythmias depending on the heart rate. So if you have a patient with a heartbeat between 60 and 100, that is a normal heartbeat, so he doesn't have arrhythmias. But if the heartbeat are increasing more than 100, then you're talking of tachycardia or tachyarrhythmias. So they are called tachycardia or tachyarrhythmias if you have a heart rate of more than 100 beats per minute. It's called tachycardia. And these tachycardia are divided into, if you have a heartbeat between 100 to about 250, these are called tachycardias. Then if you have a heart rate between 250 and 350, they are called flutter. So flutter, F-L-U-T-T-E-R, flutter, if you have a heart rate between 250 and 350. That is called flutter. It means you have an increase in heart rate. Then if you have an increase in heart rate to greater than 350, so greater than 350, then you're having fibrillations. So fibrillations is an excessive increase in the heart rate that can be brought about because of other foci of cells that are producing spontaneous action potentials that are driving the ventricles very crazy. The ventricles will be becoming crazy because the rate at which they are going to contract to be very fast. So they'll be even pumping less blood, because if they are not given enough time to relax, you find that they are not be able to fill with blood so that they pump normal volume, the stroke volume. So if they are pumping very fast, that will bring about fibrillations. You find that even the cardiac output will reduce. That will bring about weaknesses, and that's a severe case, the patient can die. So those are tachycardias. Then coming down, if the heart rate is reducing, then they are called bradycardia. So bradycardia is a reduction in heart rate. So a heart rate between 40 and 60 is called mild bradycardia. So sometimes you can't see clinical signs with mild bradycardia because under normal circumstances, when the patient is resting, you won't be able to see any clinical signs with bradycardia because the patient will still be conscious with that kind of heart rate. Then if the heart rate is reducing from 20 to about 39, then you're going to have moderate bradycardia. So moderate bradycardia between 20 and 39. If you have a heart rate between 0 and 19, then you're going to have severe bradycardia. In this severe bradycardia, it will bring about clinical signs because now the heart is not pumping much blood. Then you have weaknesses, then you have dizziness, sometimes fatigue. Then you can even have syncope if that is happening. So those are different classifications of cardiac arrhythmias. So now let's just go in detail, just discussing these cardiac arrhythmias. So cardiac arrhythmias, heart malfunction as a result of abnormal rhythm of the heart. So there is just abnormal rhythm of the heart. That's why they are called cardiac arrhythmias, abnormal rhythm of the heart. By now you understand the normal rhythm of the heart. So anything outside the normal, it's called cardiac arrhythmias. So there are different causes of these cardiac arrhythmias. So the causes of cardiac arrhythmias are usually one or a combination of the following abnormalities in the rhythmicity and conduction of the heart. So if you have abnormalities in the rhythmicity and conduction of the heart, that can result into cardiac arrhythmias. So what are some of the causes of these cardiac arrhythmias? It could be one of the factors listed here, or it could be a combination of two or more factors that are listed here. So the factor number one that can cause cardiac arrhythmias is abnormal rhythmicity of the pacemaker cells. So if the pacemaker cells are slowing down in production of these action potentials, you know, to say the heart rate will reduce. If the pacemaker cells are increasing the production of action potentials, it will also increase. So the abnormal rhythmicity of the pacemaker cells can result into cardiac arrhythmias. A shift of pacemaker from the sinus node to another place within the heart. So if there is another place within the heart that are exhibiting spontaneous activities of action potentials, that can result into cardiac arrhythmias, because we said for you to have a normal cardiac rhythm, the source of action potential should just be the SA node. So if it's coming from elsewhere, then that can result into cardiac arrhythmias. And then blocks at different points in the spread of impulse through the heart can also result into cardiac arrhythmia. So you're talking of heart blocks. So if you're having heart blocks, it means the conductivity of action potential is somehow being interrupted. So because of that, it can result into cardiac arrhythmias. And then abnormal pathways of impulse transmission through the heart. So if you have an abnormal pathways, it's not coming from the SA node, internodal fibers, AV, bundle of His, bundle branches, Purkinje fibers. If you are having any pathway that is not moving into this normal pathway, then you can also have cardiac arrhythmias. Maybe the pathway is starting from the atria, not SA node. Or maybe the pathway is starting from the ventricles. So that will result into cardiac arrhythmias because this is not the normal pathway. Then sometimes you can have spontaneous generation of impulses in most part of the heart. So if you have these spontaneous activities in most part of the heart, this one is firing an action potential, another cell is firing another action potential. So there will be no coordination between the atria and the ventricles that can also bring about cardiac arrhythmias. So there are different types of cardiac arrhythmias. Then heart blocks, which are also special types of cardiac arrhythmias, they are as a result of interference in the conductivity of action potentials. So to some extent, there'll be maybe a delay in the conductivity of action potentials. That's why they are called heart blocks. You are blocking the passage of action potentials. So it's either you are slowing down the conductivity of action potentials or you are completely stopping the conductivity of action potentials. So it will bring about heart blocks. So heart block is a delay in the conduction of electrical current as it passes through the atrioventricular node or bundle of His or both bundle branches. So sometimes you can have slowed down or bundle branches, you can have partial block or a complete block. Then all of which are located between the atria and the ventricle. So you know to say the normal conductive system of the heart is between the atria and the ventricle. So the blockade is between the atria and the ventricle. This is where you find heart blocks. So some types of heart blocks cause no symptoms. For instance, if you have a heart block, which is a partial heart block, maybe it's just reducing the heart rate because it's reducing the conductivity of action potentials. That can just result into a cardiac arrhythmia that you can't really appreciate any symptoms. When the patient is just resting, they will just have normal function of the body because they still have the action potentials that are being propagated to the ventricles. But others cause fatigue, dizziness, fainting. So if the heart block is severe to the extent that is blocking, completely blocking the movement of these action potentials, it can bring about fatigue. For instance, if the action potentials are not moving from the atria to the ventricles, of course, the atria could be contracting, but the ventricles, the rate at which the ventricles will contract will change, maybe to reduce, maybe to pick up another rhythm because of the escape rhythm. You can have an escape rhythm whereby the SA node action potentials are not being propagated to the ventricles, then the ventricles will escape that by producing an action potential of their own. Maybe it's coming from the AV node, or maybe it's coming from the bundle of His, or maybe it's coming from the ventricles themselves. So they're going to contract, but the rate at which they're going to contract, it's going to be slow. Then that will result into a reduced heart rate or a bradycardia. In this bradycardia, you're going to have a reduced cardiac output that will bring about muscle fatigue, because for the muscles to metabolize, they need oxygen, they need nutrients so that they are able to produce ATP. So with less oxygen, less production of ATP, that will bring about muscle fatigue. Dizziness, you need constant supply of oxygen and nutrients, especially glucose, to the brain cells. So if the brain cells are not receiving enough oxygen and nutrients, you'll find that their metabolism will start reducing, and then that can bring about dizziness. And then sometimes you can even lose your conscience. So it can bring about fainting or syncope if at all the supply of oxygen and glucose is reduced so much to the extent that the brain cells are not accessing enough energy, in short, then that can bring issues of fainting or syncope. Then you have the electrocardiography, which is the device that is used to record the ECG. So this electrocardiography is used to detect heart blocks. So on the ECG, you'll be able to pick up certain heart blocks. That's why we're having this discussion here. We'll be able to discuss when you're looking at the ECG, how can you tell what type of heart block or what type of cardiac arrhythmias it is? So you'll be able to pick up that. So there are different types of cardiac arrhythmias. Other cardiac arrhythmias or heart blocks would require an artificial pacemaker. For instance, if you have a complete block of the AV or the band of His, meaning that the electrical activities that are coming from the atria, they are not able to pass into the ventricles. So the ventricles will be independent from the atrial activity or the pacemaker cells. So that will result into now abnormal cardiac rhythm or arrhythmias. So sometimes to treat that, there are artificial pacemaker cells that can be implanted into the heart. Then they'll be able to stimulate the ventricles to contract at the normal rate. So that's one way of treating heart blocks, especially complete heart blocks of the AV node or the bundle of His. So this is where you can use the pacemaker, an artificial pacemaker. So there are different types of these heart blocks. You can have SA nodal blocks, so the Xenoatrial nodal blocks. So you're blocking the SA cells or the pacemaker cells, or you can have atrioventricular blocks. The atrioventricular blocks, they are also called AV blocks. So AV blocks, you're looking at the AV. So the AV node and also the bundle of His that are coming from the AV node. Then you also have bundle branch blocks. So you can have Hemi blocks, or you can have partial block or complete block. So these are different types of heart blocks that we'll be discussing. So let's go and discuss now some of these. So in general, this is just a slide summarizing different types of heart blocks depending on which structure is being blocked and what type of block it is, whether it's a transverse blockade or whether it's a longitudinal blockade or whether it's a combination of different types of heart blocks. So part A here, you have the transverse blockade, meaning that the plane of blocking this portion of the heart is transverse or horizontal. That's why they are called transverse blockade. So you have different types of transverse blockade. You have a sinus blockade shown in one here. You can have arterial blockade shown as 2 here. Then you can have atrioventricular blockade, which could be a partial or a complete blockade. So these are different types of AV blocks. So these are called transverse. Then you can have longitudinal blockade. So you are blocking the conductive system in a longitudinal plane. So these are called longitudinal as opposed to transverse. So the longitudinal ones, you can see here that you have one shown in 4 here. So this 4 is called a blockade of the right bundle branch block or right bundle branch block, meaning that you know to say the bundle of His is going to divide into 2. So you have right and left bundle branches of His. Then on top of that, you need to understand that the left bundle branch of His is also going to divide into 2. So you have the anterior and the posterior bundle branch of His. These are, so you have bundle branch that is dividing into 2. So you have the left bundle branch of His and the right bundle branch of His, but the left bundle branch of His is also going to divide into 2, forming the anterior and posterior. So the anterior is supplying the anterior aspect of the heart, then the posterior is also supplying the posterior aspect of the heart. So these are the ventricles, because the left goes to the left ventricle, the right goes to the right ventricle. So this is what it looks like. So you can see here that the right bundle branch is just 1, but the left bundle branch is going to divide into the anterior and posterior branches. So you can have transverse blockade, for instance, shown in 4 here. If you block the right bundle branch, so you have the transverse bundle branch blockade or a block. Then you can have the left bundle branch blockade, whereby you block maybe the anterior or the posterior, or you can block all the branches, the anterior and the posterior part of the left bundle branch. So I hope you understand. So the 4 is for right bundle branch block, which could be partial or complete. Then you have shown in 5 here. So 5 is left bundle branch block. So you're blocking both the anterior and posterior. That's why it's just called left bundle branch block. And then 6, you can just have a blockade of anterior upper branches of left bundle branch block. So if you're just blocking the anterior or you're just blocking the posterior, these are called Hemi blocks. This is where Hemi blocks comes in. So Hemi blocks, you're just blocking maybe the anterior or the posterior part of the left bundle branch of his. So these are different types of heart blocks. But sometimes you can have the combination of two, whereby you have the right bundle branch block that is accompanied by the maybe the anterior or the posterior or both. So if you have 4 plus 6, this is called block Bailey. So block Bailey is a blockade of the bundle branches, in short. So if you have the left and the right bundle branch blocks, then you have a combination which is called a block Bailey. So these are just in general different types of heart blocks. So now let's go in detail by looking at the ECG, how it will come out, and how are you able to know that this is a SN node block or anteroventricular block, first degree, second degree, third degree. So that's what we'll look at. So let's speed up. So let's start by looking at the Xenoatrial nodal blocks. So you know to say the Xenoatrial nodal blocks, you are blocking the passage of action potentials from the AV node, from the SN node, from the Xenoatrial node to the AV node. So when that happens, it means that you can have situations whereby when you're looking at the ECG tracing, you don't appreciate the P waves, right? It's because the P waves are only produced when you have an action potential from the SN node that has been transmitted to the two atria. So the depolarization of the atria, it will bring about the P waves. So without an action potential from the SN node being transmitted to the atria, you won't appreciate the P waves. So sometimes you can have cessation of P waves. You won't appreciate the P waves in the ECG. So you can have them and sometimes you don't have them, depending on the severity of the block. So you can have partial or complete. So the impulse from the sinus node is blocked before it enters the atrial muscle. There is sudden cessation of P waves with resultant standstill of the atria. So it means you can't appreciate the P wave because this action potential is not being transmitted to the atria. So there's no depolarization of the atria, then it means you can't appreciate the P wave. But sometimes you can have an escape rhythm whereby the atria will fire an action potential on their own, depending on the severity of the block. So the ventricles pick up a new rhythm, the impulse usually originating spontaneously in the atrioventricular node. So it means that if the AV node is not firing the action potential to depolarize the atria, it's also not firing an action potential to be transmitted to the AV node. So the AV node won't be receiving an action potential from the SN node in Xenoatrial nodal blocks. Because of that, the atria will pick up their own rhythm. So they will start producing their own action potentials at the rate between negative 40, at the rate of 40 to 60 action potentials per minute. So it will bring about bradycardia because you know to say the heart rate will reduce because these action potentials are now coming from the AV node and not from the SN node. So the rate of the ventricular QRST complex is going to be slowed down. That will bring about bradycardia. The SN nodal blocks rarely give symptoms. So they are rarely going to give symptoms because the AV node is still firing at the rate between 40 and 60. So you're going to have mild bradycardia in which you're not going to see symptoms in this patient, unless if you subject the patient to a certain type of exercise, and then that's when you can now appreciate shortness of breath. Sometimes you can appreciate the patient becoming so weak, fatigued, because that kind of heart rate can't sustain certain activities like exercise. So you are able to tell that, but just not to say that the heart rate will be between 40 and 60 because the action potential is originating from the AV node, which is now acting as the pacemaker cells. The SA node is not doing that. So there are different types of SA node blocks that would include SA node winky back. So winky back type 2, type 1, SA node Morbis type 1. So the SA node winky back, this is Morbis type 1. Then you have SA node Morbis type 2, then SA node exit block. So this diagram, you'll be able to appreciate what will happen to the ECG tracing. So the first one here, you can see is the sinus bradycardia. So let me just use a pencil to draw so that you appreciate what is happening here. So in sinus bradycardia, from the word itself, sinus bradycardia, it means that the SA nodes, they are not firing action potential at the normal rate. So it's reduced. So for some reason, maybe there's a pathology taking place there. Maybe there's a drug that is inhibiting them to produce enough action potentials. Maybe it's due to acetylcholine, because you know to say parasympathetic will have a negative dromotropic, chronotropic, and inotropic effect on the heart. So if you have sinus bradycardia, you have normal P wave access with heart rate of less than 60 beats per minute. So it means that these pacemaker cells, they are firing action potentials at less than 60 action potentials per minute. That will bring about heart rate of less than 60 beats per minute. So you can see here that there is elongation of R to R interval. So you can see under normal circumstances, it's not supposed to be this elongated. So you have a bradycardia because you have elongation of R to R interval. So you have this elongation of R to R interval, but every P wave is followed by QRS complex. So you can see here, there's a P wave that is followed by QRS complex. So you find that every P wave is followed by QRS complex, but there's a slowdown in the activity of the pacemaker cells that will bring about bradycardia. So this is called sinus bradycardia. But each and every P wave is followed by QRS complex. So it means they're being conducted to the ventricles. There is communication between the ventricles and the SA node. Then the next one is called sinus arrest. So sinus arrest, from the word itself, you are able to tell that when you have sinus arrest, then it would mean that maybe there's a P wave that is not being conducted to the ventricles. So here during sinus arrest, there are normal P wave access. So you can see there are normal P wave access. Then every P wave followed by QRS complex. Then there are pauses of 3 or greater than 3 seconds without arterial activity. So you can see here without arterial activity, hence the name sinus arrest. So you can see from this diagram that there's this P wave followed by QRS complex. Then here you also have another P wave followed by QRS complex. But here you have the T wave. Then you can't appreciate any P wave here. So here there are drops in heartbeats. So this portion here, there's an arrest of the sinus. So you can see that the sinus is not firing action potentials within this portion. So this will result into a sinus arrest whereby you don't have arterial activities because you don't have a P wave to stimulate the atria to fire that action potentials. So you can see from here that this is an example of sinus arrest. Then we move on to Xenoatrial exit block. So you have Xenoatrial exit block. So it means the sinus is firing an action potential, but this action potential is unable to be propagated to the atria, then to the ventricles. So what happens? You're going to have a normal P wave access. So here you have this normal P wave access. So remember, once the SA node fires an action potential, it's either going to stimulate the nearby myocardial cells that will be able to depolarize the other myocardial cells or the atria because they have gap junctions. So they don't need those conductive systems. So once there is a firing of an action potential within the SA node, it will be able to be passed to the atria. So you're going to have a normal P wave access. Then there is progressive shortening of PP interval until one P wave fails to conduct. So you can see here, from this P wave to another P wave, which is here, then you have this P wave to another P wave, which is here. So you can see there is shortening in the PP interval. So this PP interval, there is shortening the PP interval until there is a drop in the P wave. So once you have a drop in the P wave here, you're not seeing any P wave, you're also not going to see the QRS complex. So there is no P wave, and then there is no QRS complex. This is due to Xenoatrial exit block. So it means that some of the action potentials, they are being allowed to move, but at some point when it's becoming severe, it's not going to allow propagation of an action potential. So you're going to have a drop in the beat, then you're going to have a missing QRS complex. So this is Xenoatrial exit block. Then sometimes you can have bradycardia, tachycardia syndrome. So bradycardia, tachycardia syndrome is whereby you have intermittent, whereby you have an increase in the heart rate followed by missing heartbeats. Then you also have the bradycardia within the same patient. So you can see from this ECG that the PP interval here is reduced. So if the PP interval is reduced, it means you're going to accommodate more heartbeats per minute. So this portion is showing tachycardia. So here you have a tachycardia that is followed by a portion where you have dropped beats. So here beats are dropped. So you have dropped beats. They are dropped here. You can see a P wave. You can see a QRX complex here. So you have dropped beats that are followed by elongated PP interval. So if you have elongated PP interval, you have a reduction in heart rate. So this is a bradycardia that is taking place here. So you have bradycardia, tachycardia syndrome within the same patient. So I hope that is clear. Then you can also have another diagram here that is explaining Xenoatrial blocks. Okay, so this is another diagram that is also looking at the Xenoatrial block. So you have the second degree Xenoatrial block type 1, in which you have a gradual shortening of PP interval with an eventual dropped P QRST complex. So you can see here again that you have a gradual shortening of P to P interval. So it's shortening. Then at some point, you can't appreciate a PQRST segment in this portion here. So the PP interval are reducing. Then at some point, you don't have the QRS complex. So it means this is the second degree Xenoatrial block type 1, which is also called the Winky-Back Xenoatrial block 1 or Morbis type 1. Then you have Xenoatrial Morbis type 2. So the Morbis type 2 here, you have a situation whereby you have the PP interval surrounding the pulse is 2 to 3 times the length of the baseline PP interval. So you have the PP interval surrounding the pulse or the pulse is 2 to 3 times the length of the baseline. So you can see here instead of having a gradual shortening in the PP interval, here now we have lengthening of PP interval. You can see it. This is just a normal P interval. So if you see P to P interval, here it's just normal. But somewhere here, you can see that there is elongation of PP. So from this P to another P, it's elongated. From this P to another P again, it's elongated. Then where you have this elongation of PP interval, sometimes you don't see a QRS complex that is followed by that. So once you see this elongation of PP interval, then most likely you're looking at second degrees, atrial block type 2, which is called Morbis type 2. So remember these Morbis type 2, they are also applying to the AV node. So let's move on to the AV nodal or AV blocks in short. So we move on. Okay. So these SA nodal blocks, they are not very important because you won't really appreciate clinical signs. So the most important heart blocks are called the atrioventricular heart blocks. So you have atrioventricular blockade, which are also called AV blocks. So here you need to pay attention because these will bring about clinical signs. So let's start. So the only means by which impulses ordinarily can pass from the atria into the ventricles is through the AV node. To say it has to go through the band of His. So this is just a normal pathway. So what are the major causes of AV blocks? So there are different causes also for AV blocks. So sometimes you can have ischemia of the AV node or AV bundle fibers. So if you have less oxygen supply or if you have ischemia of AV node, it means they're not receiving oxygen, they're not receiving nutrients. That can result into necrosis of the AV node and also the AV bundle. So if you have damage to these cells, then they can interfere with the conduction of action potentials, which will bring about AV blocks. And then sometimes you can have compression of the AV bundles, inflammation of the AV node or AV bundle. So if you have inflammation like pericarditis, then inflammation of the valves, it can also interfere with the function of these bundles. So that inflammation can also affect the AV node or the bundle of His. That will bring about AV blocks or abnormal conductivity of these action potentials or complete blockade of the action potential. Sometimes you can have extreme stimulation of the heart by the vagus nerves. So to say the vagus nerve is mainly producing acetylcholine. Remember, you have the preganglionic neuron and the postganglionic neuron. So in parasympathetics, they are all cholinergic nerves. So the preganglionic is producing acetylcholine, the postganglionic is also producing acetylcholine. And this acetylcholine has got an effect on the SA node and the AV node. So with much stimulation of the vagus nerve will result into production of acetylcholine that will go and bind to M2 receptors, muscarinic receptors that are found within the SA node and the AV node. They're called H2 receptors or M2 receptors. The M2 receptors or muscarinic receptors, number 2, they have a negative chromotropic effect on the heart, a negative dromotropic effect on the heart, and a negative inotropic effect on the heart. So they are going to reduce the conductivity of action potentials. That will bring about heart blocks. That's why during breathing, you find that there is change in terms of the heart rate. So you realize to say that when you start looking at the respiratory system with Dr. Mshalati, he will tell you to say during inspiration, there is an increase in vagal inhibition. So if there's an increase in vagal inhibition during inspiration, that will result into an increase in the heart rate. So to say during inspiration, there is vagal inhibition. So once there is vagal inhibition, it means that you don't produce a lot of acetylcholine to inhibit the conductivities of action potentials. So during inspiration, remember that heart rate increases. During expiration, heart rate will reduce. Why? Is because the heart rate is going to reduce because there is disinhibition or vagoinhibition. So remember, there is disinhibition or vagoinhibition, meaning that during expiration, the vagus won't be inhibited. So there will be production of acetylcholine. That will bring about reduction in the heart rate. So during inspiration, an increase in the heart rate. During expiration, there is a decrease in the heart rate. That is called physiological sinus bradycardia, if you want. So it's just a normal physiological sinus bradycardia because it's going to inhibit the SA node and the AV node. So just not to say that if you have extreme stimulation of the heart by the vagus nerve can also bring about atrioventricular or AV blocks if you want. So we proceed. Let's look at these AV blocks on the ECG. How can you tell the different types of AV blocks on the ECG? We speed up. So this table here is showing you different types of AV blocks. So I'll take my time so that you understand. So you can see there are different classifications of AV blocks or different types of AV blocks. There is first degree AV block, second degree, the first degree AV block, second degree AV block, and then you also have another second degree AV block because you have different types. You have Morbis type 1, which is also called Winkie-Back. And then you have second degree AV block, Morbis type 2, and then you have other classifications whereby you have second degree, that is called 2 to 1 block. I'll explain all that. You understand in the third degree whereby you have complete blockade of the AV node. So there is no communication between the artery and the ventricles. So let's start with the first degree AV block. Okay, so let me also get my pen so that I'm able to explain from the diagram. Okay, so let's start with the first degree AV block. So the first degree AV block is also called prolonged PR or PQ interval. Under normal circumstances, the normal range of PR-PQ interval in a normal ECG should be between 0.12 to about 0.2. So on average, the PQ interval should be between this normal range. So the usual lapse of time between the beginning of P wave and the beginning of QRS complex should be 0.16. So this is the average. So the average time for PQ interval, PR interval should be 0.16. So in first degree AV blocks, there is prolonged, so you can see here, it's prolonged PR interval. So here you have consistently prolonged. So mark the word consistently prolonged, meaning that this prolongation of PR interval should be always the same in terms of the time or the duration. So you can see from this first degree AV block, you have this P wave. So the beginning of P wave to the beginning of QRS complex is called the PR interval or PQ interval, because sometimes you don't have the Q wave. So it's also referred to as PR interval. So in this diagram here, you can see the beginning of P wave. So it's starting somewhere from here all the way to the beginning of QRS complex. So this is called the PR interval. PR interval. So you can see that this PR interval is elongated here. Under normal circumstances, it's supposed to be 0.16, or maximum should be 0.2 seconds, or one big box. But you can see here is prolonged. Then when you check here again, you have your P wave, so the beginning of P wave to the beginning of QRS complex. Then you have your P wave here, the beginning of P wave to the beginning of QRS complex. So you can see that these PR interval are prolonged, but they are also consistent. So because they are prolonged and consistent, it would mean that there's a slowdown in the conductivity of action potentials at the AV node. So you have the first degree AV node, meaning that each and every P wave is conducted, then to produce a QRS complex. You can see a P wave with QRS complex, a P wave with a QRS complex, but there is prolongation of PR interval than the normal range. So any PR interval greater than 0.2, but this PR interval is consistent, then that will qualify to be the first degree heart block. Okay, so we are done with the first degree heart block. Let's go to the second degree heart block. Okay, so this is the second degree heart block. This is just the general information for the second degree heart block. So the first degree heart block, the first thing that you need to know is that you have prolongation of PR interval, but this prolongation is consistent from one beat to another beat. So you have prolongation of PR interval, which is consistent. Then you have the first degree heart block, which is a partial heart block, meaning that there's just a slowdown in the conductivity of action potential, but each and every P wave will manage to go through the AV to the ventricles. So you have the first degree heart block, and then you have the second degree AV block. So the second degree AV block, you have different types, but in general, when conduction through the AV node is slowed enough to increase the PR interval to between 0.25 to 0.45 seconds. So we say that when AV block is greater than 0.2 seconds, then you have prolongation. If that prolongation is consistent from one beat to another beat, then you have first degree AV block. But here, if you have prolongation of between 0.25 or 0.25 to 0.45 seconds, then the action potential sometimes is strong enough to pass through the bundle to the ventricles. And then sometimes it's not strong enough to pass. So it means that other P wave won't be followed by QRS complex. So you have prolongation of the PR interval, but sometimes a P wave is not followed by QRS complex. Then you have a second degree AV block, which is more severe than the first degree. So in the first degree, all the P wave were being conducted to the ventricles. But here now you have prolongation of PR, but on top of that, you have a missing bit, or you have a missing QRS complex. So not all the P wave are being conducted to the ventricles. Then you have a second degree AV block. So in this instance, there will be an atrial P wave, but no QRST wave. And it is said that there are a drop beat or dropped beats of the ventricles. So it means the ventricles are not being contracting because one of the P wave is not being conducted to the ventricle, so that you have the QRS complex. So this is a second degree heart block. So you have different types of second degree heart blocks. This is why it gets complicated, but it's very simple if you look at it. So the second degree heart blocks, just not to say you have prolongation of PR interval, and on top of that, you can have a drop in the heartbeat. So you have dropped heartbeats. So there are different types of second degree heart block. So there's type 1. So you have more beats type 1, second degree AV block. So let me also get my pencil so that I explain, so that you understand again. So you have more beats type 1, second degree AV block. So there is prolongation of, there is progressive lengthening of successive PP interval. So here, the word is progressive lengthening of PR interval. So you need to mark this word in first type or morbid type 1, second degree AV block. So there is a progressive lengthening of successive PR interval. On top of that, the PR interval progressively increases until a P wave is not conducted. So you find that the PR interval will progressively becoming elongated until one P wave is not conducted. So you find that there's a drop in the P wave. So you won't appreciate a P wave that is associated with a QRS complex because it's not being conducted to the bundle of His because there's that block. So the cycle repeats itself and is referred to as Winkie-Back phenomenon. So the Winkie-Back phenomenon is whereby you have prolongation of PR interval. So there is progressive prolongation of PR interval, and then you have a P wave that is not associated with QRS complex. Then you have morbid type 1, second degree AV block. So the main thing that you need to note here is progressive lengthening of successive PR interval. So when you come this side on your ECG, so you have PR interval. You're talking of PR interval. So this is from the beginning of the P wave to the beginning of QRS complex. So you can see from here, the beginning of P wave to the beginning of QRS complex. Then this is the first one. The second one, you have progressive prolongation, so to be longer than the first one. So the second one, you can see is starting from here, the PR interval to the beginning of QRS complex. This is the second one. So the first PR interval is shorter compared to the second PR interval, which is shown here. Then the third one, you can see starting from here, the beginning of P wave to the start of QRS complex. So the third one is even much long, or it's longer than the second one. So there is a progressive increase in PR interval. Then at some point you find that a P wave is not followed by a QRS complex because it's not conducted to the ventricles. So you can see there's a P wave here, but you can't see the QRS complex, you can see another P wave. So it means that in between here, there's a missing QRS complex. So this missing QRS complex is as a result of this P wave that is not being conducted to the ventricles. So you won't see this QRS complex. So it means when you have progressive elongation of PR segment, then a missing QRS complex, then you know to say that you have morbid type 1, which is a second degree. So the easy way to remember this, you have a word which is saying longer, so longer, then a drop. So if you say longer drop, meaning that the P wave is becoming longer, then you have a drop in QRS complex, then this is called a morbid type 1, which is also called the Winkie-Back heart block. So it's also called a Winkie-Back heart block. So I hope you remember that. So we move on to another type. Okay, so you can see in morbid type 1, we said there's progressive lengthening of successive PR interval, and then sometimes you have a dropped QRS complex because a P wave is not conducted to the ventricles. So this is morbid type 1 or Winkie-Back heart block. So in this diagram, you can appreciate that as well. So you can see in this diagram that you have progressive elongation of PR interval. Then later on, you have a drop in QRS complex. Even here, you can see to go back to the normal, then you have a progressive elongation of PR interval. Then you have a part whereby you have a dropped heartbeat without a QRS complex. A P wave without QRS complex. So this is a Morbis type 1, second degree AV blocks, which is called Winky back. To proceed, let's look at Morbid type 2, second degree AV block. So let me just get back my pencil. Okay, so we said in second degree type 1, Morbis type 1 or Winky back, we said there's progressive prolongation of P wave or PR segment. Then you have a drop in QRS complex. So you can remember by saying longer drop. Then for the first degree, how can you remember this? You have consistent, so you have consistent elongation of PR segment. So once you have a consistent elongation of PR segment without a drop in P wave, you have without a drop in QRS complex, then you have first degree AV block. Then moving on to the second degree AV block, which is called Morbis type 2. So now we're moving on to Morbis type 2. So we are still within the second degree. Second degree, it means there's a missing QRS complex somewhere. So if you have progressive elongation of PR interval with a drop in QRS complex, then you have a type 1 or Morbis type 1, which is called Winky back. But now, how can you differentiate it from Morbis type 2, second degree AV block? So the PR interval of conducted beats is normal, but some P wave are not conducted. So here you can see that PR interval is normal, but some P waves are not conducted. So this is how you differentiate the two. So when you come back to this diagram, you can see the start of the P wave to the start of QRS complex. This is your PR interval. So this is your PR interval. So this PR interval is normal. Then when you check again your PR interval here, there is no elongation of PR interval, it's still normal. Then you can also check here the PR interval within the normal range. So you have PR interval that is normal, but you have a P wave that is not conducted. So here you have this P wave, but this P wave is not followed by a QRS complex. You have another P wave here. So there is a missing QRS complex, just like in Morbis type 2. But the difference here is that the P wave are consistent. So PR interval are consistent. So these PR interval are consistent, but they are coupled with a P wave with a missing QRS complex. So it means when you have PR interval, which are consistent, same here, here, and here, but you have this P wave with a missing QRS complex, then you have a Morbis type 2. So it's different from Morbis type 1. So the Morbis type 1 is affecting the AV node cells themselves. So that's another difference. So the type 1, Morbis type 1, what is being affected are the AV nodal cells. So AV node is affected. AV node cells are affected, so they are not conducting an action potentials. That's why you have prolongation of these P wave, then later on you have a drop in QRS complex. But in type 2, what is being affected here is below the AV node. So it's a bundle branch, but below the AV node. So it's below the AV node. So it's a AV block, but the block is below the AV node. So what does that mean? It means that the AV node is firing an action potential, but this action potential can't move via the band of His because that's where the block is. So that's why you find that you have normal PR segment, because the PR segment, mainly you're looking at AV delay. So you have AV delay. So the AV delay is the one that will give you the PR segment or PR interval. So this PR interval in Morbis type 2 will be normal. Why? It's because the AV node cells are okay. So there is normal delay within the AV node, but this action potential can't pass through the band of His. This is where the block is. That's why you have a missing QRS complex. So sometimes it can pass through and then sometimes it won't be allowed. Then you have a missing QRS complex. And the other difference is that when you do a vagal maneuver, so if you're doing a vagal maneuver, when you stimulate the vagus nerve, you find that that vagus nerve will have an effect on Morbis type 1 because these cells are the ones that are not functioning well. So you find that if you have a vagal maneuver, it's going to worsen the situation in type 1. But in type 2, it's because the band of His, they don't have those receptors. The M2 receptors are not much there within the band of His. So you find that it's not affected by vagal stimulation or vagal maneuver. Even if you stimulate the vagus nerve, the acetylcholine will have less effect here or no effect as compared to here, because within the AV node, you have the M2 receptors that will be affected by the parasympathetics. So this will be affected by the parasympathetics. This won't be affected by the parasympathetics. Then you know to say these are two different types of Morbis, second degree AV blocks. So you have Morbis type 1, Morbis type 2. So we move on. So you can see from this diagram again, it's just the same Morbis type 2. So you can see that there is a normal PR interval from here to here. Then there's a missing wave. So you can see from here that you have normal PR interval. Even here it's normal, but you have a missing QRS complex here. So you have the normal PR interval, but you have a missing QRS complex. So this is an example of Morbis type 2. Okay, so move on to AV block. So this is complete AV block. So a complete AV block is also called a third degree block. So meaning that now you're not allowing any sort of action potential to pass through the AV node and also into the band of His. So there's no communication between the AV node and the ventricles. So what happens? And then you have a complete AV block. So the second degree is not complete. That's why some of the action potential are passing through, others are inhibited. So now when you have a complete AV block, what would happen? So when the condition causing poor conduction in the AV node or AV bundle becomes severe, complete block of the impulse from the atria into the ventricles occurs. So in this instance, the ventricles spontaneously establish their own signal, usually originating from AV node and AV bundle. Therefore, the P waves become dissociated from the QRS complexes. Note that the rate of the rhythm of the atria in this electrocardiogram is about 100 beats per minute, whereas the rate of ventricular beat is less than 40 beats per minute. Furthermore, there is no relationship between the rhythm of the P waves and that of the QRS complexes because the ventricles have escaped from the control of the atria and they are beating on their own natural rate. So you're talking of the second degree AV blocks. So I'll get my pencil again for you to understand the explanation. I'll have to draw again. So let's get back. So this is now a complete block. So a complete or third degree AV block, which is down here, you can see that there is no communication between the atria and the ventricles. So the atria are contracting on their own, the ventricles are contracting on their own. Why? It's because you know to say that you have the two atria, then you have the two ventricles down there, and these are only communicating via the SA node and the AV node that is conducting to the muscle fibers. Maybe I use a different ink here. So I'm saying the two atria are communicating with the two ventricles via the SA node, AV node, then the bundle of His. Then you have the left branch and the right branch of the bundle of His that is supplying the ventricles. So if you have a complete block, meaning that it's completely cut off here, meaning that the two atria are contracting on their own and the two ventricles are contracting on their own, then you have a complete block. So what would happen? When you go back to this formula, to this ECG tracing, you can appreciate P waves. So you can see here, there's a P wave, then here, there's another P wave, then you have a P wave here, then you have this P wave here. Then this is also a P wave. Then you have QRS complex, QRS complex, QRS complex. So what you need to know is that when you have a complete AV block, you are going to have a consistent PP interval. So P to another P, it will be consistent. So you find that this P here to another P, this distance will be the same from this P to another P, then it will be the same from this P to another P. So you have consistent or matching P to P interval. Then you also have consistent R to another R interval. So this interval is also consistent from one R to another R. But what you realize is that there is no coordination between the P waves and the QRS complex, meaning that the atria are contracting on their own and the ventricles are also contracting on their own. So the atria are contracting due to the firing of SA node, the pacemaker. So you find that the P wave, you have the normal range of the P wave, that is between 60 to 100 P waves per minute. But when you check the frequency of QRS complex or R to R, you have less QRS complex. So you have QRS complex, so these are P waves. Then the QRS complex, there will be less. So there will be between 40 to 60. Why? It's because the ventricles are contracting on their own. So because the AV node is blocked, it means that the ventricles will start contracting on their own. So you have a pacemaker maybe that is originating from the bundle branch, and the bundle branch will produce action potentials at that rate. And also the ventricles can also produce from 15 to 30. So you find that the ventricles contraction will reduce and the P wave will be within the normal range. So it means that the ventricles are contracting on their own and also the atria are contracting on their own. The atria are contracting due to the stimulation from the SA node. Then the ventricles, they are not, that action potential is not being transmitted to the AV node, so it means that they will develop their own action potentials. So they'll start contracting their own. So there is no coordination between the P wave and QRS complex. So you can see this P wave is not followed by QRS complex. Even this one, it can be followed by QRS complex, but it's not as a result of the conduction of this P wave because it's not being conducted. So you have the ventricle here that is contracting on its own. Then you can have a T wave here because QRS complex, you're going to have QRST complex, QRST. So you have the QRS and the T wave, but there's no correlation with the P wave. So after just the P wave, after the T wave, you have the P wave here. So it means that the atria, they are contracting on their own, and then the ventricles, they are also contracting on their own because there's a complete block between the SA node and the bundle branches. So there's complete AV block. So once you have complete AV block, the atria will be contracting on their own, the ventricles will be contracting on their own, then you have a third degree heart block. So this is the third degree heart block. So how can you remember the third degree heart block? It means you can have P wave match. So you have P wave match. So the distance from one P wave to another P wave, and from this P wave to another P wave, it will be the same. Then the distance from QRS complex to another QRS complex will be also the same. But there is no correlation between the P wave and the Q wave. Then you know to say that this is a third degree heart block. So that's how you can differentiate these heart blocks. And then sometimes taking you back to the second degree heart block. So taking you back to the second degree heart block, which is this one here. So we say that the second degree heart block is called morbid type 2. So here you have normal PR interval, but this normal PR interval is followed by a P wave with a missing bit. Why? It's because at this point, there's no conduction of the P wave to the ventricles. So you have the second degree heart block type 2 or morbid type 2. That's how you differentiate it from morbid type 1. So sometimes you can have this kind of cardiac arrhythmia or second degree heart block, whereby for you to classify it, you need to know how many P waves and how many QRS are there. So you can see from here, you have 1 and 2 P wave. Then here you have a missing QRS complex. Then you have another 1 and 2 P wave. Then here you have a missing QRS complex. So in this case, you have 2 waves with only 1 QRS complex. So you have 2 P wave with only 1 QRS complex. So it's also called second degree AV block 2 to 1. So it means you have 2 P waves, then you have only 1 QRS complex. So it's morbid type 2, but 2 to 1, meaning that for every 2 P waves, you only have 1 QRS complex. Sometimes you can have a 3 to 2 second degree AV block. So 3 to 2 is whereby you have 3 P's with only 2 QRS complex. So you can also classify in such a way. Okay, so we are done with AV blocks. So here we are done with the AV blocks, but maybe just another EKG tracing for you to appreciate the third degree AV block. So from here, you can see this EKG. So this diagram was gotten from Guyton. So you can see that you have these P waves. So you can see you have 1, 2, 3 P waves, 1, 2, 3 P waves with one QRS complex. Here you only have 2 QRS complex, 2 QRS complex. So you can see here for these P waves, there is no communication between the P waves and QRS complex. So because of this, you can see that there is consistent from P to P, P another P, P to P. So because you have consistent P to P, then you also have consistent R interval, R interval, R interval. It means that this is a third degree heart block. Okay, so you can't miss it. Then you have bundle branch blocks or Hemi blocks. So bundle branch, you're looking at maybe the left bundle branch or the right bundle branch or the anterior or the posterior branches of the left bundle branches. So what happens when you have bundle branch blocks or Hemi blocks? So interruption of the right and left branch of the bundle of His delays activation of the appropriate ventricle. So if you have a bundle branch, maybe left or right bundle branch, then you're going to have a delayed activation of the appropriate ventricle. It could be the right ventricle or the left ventricle, depending on which bundle branch is blocked. So that is going to result into broadening of the QRS complex. So you have a broadened QRS complex because there is a delay in the conductivity of action potentials to one ventricle. So you find that that ventricle that is affected, it will take a bit of time for it to contract. So there is a delay in the contraction of the ventricles that will bring about broadening or widening of QRS complex. So you're going to have an increase of 0.12 or more seconds of the QRS complex that is going to be broad. So you have broadening of QRS complex, produces the characteristic alteration in the QRS morphology. So the QRS is going to be broadened. So you can see from here, this QRS complex is broadened in lead 1, AVL, it's also broadened. You can see the AVL, this wave is negative because it's in the other axis. So it doesn't mean that you have abnormal wave, but just that it's broadened. And then even here in V1 is broadened, even the V4 is also broadening. So once you have broadening of the QRS complex mainly, then you'll be thinking of the bundle branch block or the Hemi blocks. So it's a type of conduction block involving partial or complete interruption of the flow of electrical impulses through the right and the left bundle branches. The bundle of His is a group of fibers that conduct electrical impulses from the atrioventricular node to the ventricles. Of course, we know, and then it's blocked in the left or right bundle branches. So the bundle branch block usually causes no symptoms. So when you have bundle branch, mainly you don't have symptoms because you just have elongation or broadening of the QRS complex, but you still have a contraction within the ventricles. Then in most cases, when you have right bundle branch block, is not serious itself. So you find that if what is being affected is the right bundle branch, that is not serious because you don't need much pressure for you to push blood to the pulmonary circulation as compared to the systemic circulation. So if you have the left bundle branch, complete bundle branch, because it can be severe, but if it's the right, then you don't need to worry so much. So this is just showing you the ECG with a broadened QRS complex because of the bundle branch block or the Hemi block. So there is a delay in conduction of action potentials to that ventricle. Because of that, it will take a bit of time for it to contract. So there will be widening of QRS complex. Okay, then this diagram is just summarizing other cardiac arrhythmias that we haven't discussed here. So for instance, sometimes you can have a normal sinus rhythm. Let me just use a pencil here as well. So here you can see down here that you have normal cardiac rhythm. Okay, so you have a P wave that is followed by QRS complex, P wave, QRS complex, P wave, QRS complex. Then after the QRS complex, you have the T wave here. So this is just a normal rhythm. So when you're looking at this ECG, it's normal. So it's called normal sinus rhythm. So whenever you see P wave, QRS complex, P wave, QRS complex, then it's basically a normal sinus rhythm. Then if you have changes like the previous slides that we've discussed, then you know to say to bring about cardiac arrhythmias. So sinus rhythm, and then the SA nodal blocks we've already discussed. Sometimes you can also have arterial blocks. So you have atrial. You have atrial tachycardia, for instance, or cardiac arrhythmias. So the atria are the ones that are affected. So if the atria are affected, sometimes you can have atrial tachycardia, atrial flutter, atrial fibrillation. So if the atria are contracting at the rate between 60 to 100, it's called normal rhythm, 60 to 100. But sometimes you find that the atria are contracting at the rate of between 100 to 250. So if it's 100 to 250, like we said, this will result into a tachycardia. So a tachycardia, you find that you have several P waves. So if you're looking at the ECG, you can have a P wave and another P wave and another P wave that is conducted to the ventricles, and then you have QRS complex. Then to start again, you have a P wave and another P wave and another P wave, and then this will be conducted. Then you have QRS complex like that. So this will point to atrial tachycardia, meaning that the atria are the ones that are contracting more. So you have maybe the Ceno that is firing a lot of action potentials, or you have ectopic source of these action potentials that will bring about atrial depolarization. Then you have more of this P wave, then one of it is conducted. So this won't be a severe case because you still have ventricular contraction and then you still have atrial contraction. Even if you don't have atrial contraction, you know to say that blood can still move from the atria to the ventricles. So you don't need to worry about these. So sometimes it can be transient. So these are called transient tachycardia. So sometimes you can have arterial fibrillation or arterial flutter. So arterial flutter, when the heart rate is between 250, so if the arterial contraction is between 250 to 350, so 250 to 350, you'll find that you have flutter. So this is called arterial flutter. Arterial flutter. So in arterial flutter, the way you're going to look at the ECG to be different. So here, because the firing of action potential has increased to 250 to 300, so you won't appreciate this P wave so much that there will be a lot of them forming like that. Then you have one P wave that will follow with a QRS complex. Then it will go back. You have these flutter waves. So these are not called P waves, they are called flutter waves. Then one is followed by a complete QRS complex. Then it starts again. So these are called flutter wave with a capital letter F. So these are the result of arterial flutter, meaning that the contraction of the atria has increased between 250 to 350. Then sometimes it can increase between greater than, let's say arterial contraction is greater than 350 contraction per minute. If it's more than that, then you have arterial fibrillation. So arterial fibrillation now. So this arterial fibrillation, when you're looking at the ECG, you're not going to appreciate the flutter waves. So here you're just going to have a straight, more like zigzag line. Then that is followed by a QRS complex. Then it goes back to a T wave. Then you have more like a zigzag line that is followed by a QRS complex. Then you have a T wave, then it starts again. This is called arterial fibrillation. So this arterial fibrillation, you find that the atria, they're not really contracting that much because they're not even relaxing. There's so much of these action potentials. So it could, as a result of the two atria, maybe the two atria, you have a source of action potentials that are overstimulating these atria. So you have the left ventricle and the right ventricle. So if you have foci of cells that are producing action potentials, so you have a lot of waves that are producing action potentials that will bring about these flutter waves. So they can't be positive or negative. So you find that it will produce more like a zigzag line and the QRS complex, a zigzag line, QRS complex. So you still have contraction of the ventricles. So you don't worry much because it's just the atria. So in this case, the heart is misbehaving. So how can you stop these fibrillation or flutter waves? This is where you can use a defibrillator. So you can use a defibrillator. So it's that kind of machine that looks like flat pads with electricity. So the defibrillator doesn't stimulate action activities within the heart. It's actually going to stop the heart. That's why it's called a defibrillator. So when you put them on the chest, they're going to stop the heart activities, then to go back to the normal rhythm. That's why it's called a defibrillator. So you find that this fibrillation can stop. So you stop them, then you start a normal rhythm, then to come back to normal sinus rhythm when you use a defibrillator. So it's not always that you use it. When you have fibrillation or flutter waves, you can use that. Then down here, you have paroxysmal arterial tachycardia. So paroxysmal arterial tachycardia, paroxysmal, it means sudden arterial tachycardia. So you can see here, you have a normal sinus rhythm here. Then you have another P wave with a normal sinus rhythm, but you have these P waves now that are so close to each other that will bring about a tachycardia. So this is sudden, that's why it's called paroxysmal arterial tachycardia. So sometimes you have a normal rhythm and then you have a sudden tachycardia. So you can see the heartbeat has increased here. So here you're going to have a tachycardia and then you have normal rhythm, you can have another tachycardia. So these are called paroxysmal arterial tachycardia. Then you have arterial fibrillation. I've already explained to you that you have these fibrillation waves, they are not called F wave. So for flutter waves, it's capital letter F. Then for fibrillation is small letter F. So these are called F waves. So it's more like zigzag. So it's small letter F. So this is arterial fibrillation. So you can see that there is overcontraction of the atria that is not coordinated because you have a lot of action potentials stimulating them. Then one of it will be conducted, and then you have a QRS complex. Then you can see that. So from the ECG, you are able to tell that this is arterial fibrillation. Then down here, you have the first degree heart block. So we said in the first degree heart block, you have elongation of the PR segment, which is consistent. So you can see this PR segment is consistent from here, even here, same duration of PR segment without a missing QRS complex. So each and every P wave will be conducted to produce a QRS complex. Then this is a first degree AV block. So the first degree AV block, you're just slowing down the action potentials. So there are slow action potentials moving across the AV node, but all the action potentials are being propagated. So this is the first degree heart block. And then you have the type 1 second degree heart block. So in type 1 second degree heart block, what you need to know is that you have progressive prolongation or elongation of PR segment or interval. So you have this PR interval that is progressively becoming longer, then the other P wave won't be conducted. You have a missing QRS complex. So this P wave is not conducted. You have this missing QRS complex here, but there's progressive elongation of PR interval. So this becomes morbid type 1. So you have morbid type 1. So it's this is second degree because there's a missing wave. Whenever you see a missing QRS complex, it's a second degree. But if you have prolongation of PR interval, then it's morbid type 1, which is called winky back. It's also called winky back. Then you have type 2, second degree heart block. This is morbid type 2. Morbid type 2, you will know to say that you have normal PR interval. So you still have normal PR interval, but you have one P wave that is not propagated to the ventricle. So you have a missing QRS complex here as well. So since you have a missing QRS complex, then it becomes a second degree heart block. But since you have normal PR intervals, then this becomes morbid type 2. The type 1, what is being affected is the AV node. So we say that the parasympathetic stimulation will have an effect on morbid type 1, but it won't have an effect on morbid type 2 because the acetylcholine is attaching to M2 receptors, muscarinic receptors. So once you have vagus maneuver or stimulation, it will worsen the morbid type 1, but it won't have much effect on morbid type 2. Then you have third degree heart block, which means that there is no in third degree, there's complete block between the AV and the ventricles, meaning that the atria are not contracting normally with the ventricles. So there is no correlation between the atria and the ventricles. So here you can see you have these P waves that result into contraction of the atria. You have QRS complex. Here you have also another P wave, P wave, P wave. So these P waves, they are not in correlation with the QRS complex. But one thing that you need to know is that the PP interval will be consistent. So from this P to another P, it will be the same time or the same distance. So you have consistent from P to P interval. Then you have consistent Q to Q interval, R to R interval, or QRS to QRS. So you can see this distance from this QRS to another QRS. It will be the same distance from this QRS to another QRS. So there is consistent P to P interval. There is also consistent R to R interval, but there is no correlation between the P waves and the QRS complex because the atria, they are contracting on their own, then the ventricles are also contracting on their own. But you need to know that in as much as atria are contracting on their own and QRS complex, the ventricles are contracting on their own, the P wave, you're going to have a normal sinus rhythm for a P wave. So you're going to have 60 to 100 P wave on the ECG when you calculate the heart rate. And then the QRS complex, it will be between 40 to 60. Sometimes it can even be less than 40. So sometimes it can even be less than 40. So you know to say that this is a third degree heart block because what is being conducted to the ventricles is not the same action potentials that is originating from the SA node. Then you can have premature ventricular contraction. Premature ventricular contraction is whereby you have a P wave followed by a QRS complex. But again, the ventricles, they have pacemaker activity of their own that are producing an action potential that will bring about abnormal contraction of the ventricle. So this contraction of the ventricle is before repolarization is complete. So you can have complete absolute repolarization or absolute refractory period, it's complete. But before you finish the relative refractory period, you find that there will be another pacemaker cell that will fire an action potential that will bring about this abnormal QRS complex. So it's called premature ventricular contraction. It's before the ventricle repolarize again, or there is no complete repolarization of the ventricle and then it's stimulated again. So it will bring about premature ventricular beat. And then you have a normal P wave, QRS complex, T wave, then another P, then maybe you can have another abnormal premature beat. Then down here you have ventricular fibrillation. So just like we had arterial fibrillation, so the heartbeat have increased here to greater than 300 action potentials per minute, but these action potentials are getting to the ventricles. So if the ventricles are being stimulated for over 360 times per minute, then it will result into ventricular fibrillations. So you can't appreciate normal wave formation on the ECG. So you just have these wave formation that are not coordinated. You can't appreciate the P wave. You can appreciate a normal QRS complex. This is not normal QRS complex. You wouldn't know which one is a P wave, which one is a Q wave, because the ventricles are just firing at a higher rate, so they are contracting. Because of this contraction, you find that the P waves are fused within these complexes, so you can't really make sense out of this. So this can be as a result of ventricular fibrillation, which is very severe and it can kill the patient. Why? It's because it means that the ventricles are not given enough time for them to relax to fill with blood. So if they're not relaxing, it means they are pumping less blood to the outside. They're allowing less blood to go into the ventricles. It will result into reduction in the cardiac output. That will bring about reduction in blood supply to the heart muscles themselves. That will bring about myocardial ischemia, and this ischemia will destroy much of the cells. Then the condition will worsen, then the patient can die. So these are the cardiac arrhythmias. So these are just examples of cardiac arrhythmias. So I hope. Okay, so this is where I'm going to end lecture 3, circulatory system lecture 3. So there is a lot of information there. When you go to textbooks, be it Canon, Guyton, especially Guyton, there is a lot of information trying to describe cardiac arrhythmias that will take much time for you to finish all those. So I hope this lecture has summarized information for you and you'll be able to understand these cardiac arrhythmias. But otherwise, if you still don't understand, you can still come through and ask those questions when you have our interactive lecture next time. I should be able to answer some of the questions that you have, because I know sometimes when you are learning these cardiac arrhythmias for the first time, it will be very difficult, especially that we didn't have a lab on ECG. So it's very difficult to explain from these diagrams and for you to grasp the information. So I just hope that this lecture video will be able to communicate to you, but even if you still have your shortcomings or you don't understand anywhere else, you can still come through and ask those questions, and I'll be happy to address those questions next time we meet. So thank you very much. So the next time we will be having a lecture again. We'll start lecture 4. Now we'll move to the simple things, because now we'll start looking at the mechanical response of the heart. You're talking about the cardiac cycle, the heart sounds, which are very simple and straightforward. So once you understand the ECG and the cardiac arrhythmias, then you are good. So the rest of the things, I think it will be very easy to comprehend, because it's just very simple and straightforward information that you can get even from any textbooks. So otherwise, thank you very much for your time. Until we meet next time. So all the best in your studies. This is where I end this class.